Thank you, Madam Speaker. What a lot to cover off on. What a lot to cover off on. So, I'd like to begin my contribution today by summarising the phrase that really captured the inquiry for those members of the LCAC. Help and choice to finish up well. So, as we went out to community and we consulted and we talked to Territorians, that was the phrase that kept coming back because I think, as the member for Fong Lim said in his contribution, when we went out and we said, "Oh, VAD," at first people said, "Oh, VAD, that sounds like bad. Are you talking about something bad?" And we said, no, voluntary assisted dying. And they said, "Well, what's that?" And then we had to explain it. And they said, "Oh, so like help to finish up." Yeah, and you've got to have choice. And we ended up landing on help and choice to finish up well. And I would have liked that to be the subtitle of the report. I'd like to start by saying thank you to the committee members. Thank you to the chair for his power of work and late nights and weekends, reading everything. I'd probably say that he's probably the member of the committee who read the most of the submissions, if not all of them. I did my best. I think, I know the member for Nguru made her way through pretty much all of the written submissions. I got through as many as I could, but not all of them, sorry to say. There's over 400, and some of them were quite lengthy. Thank you to the member for Nightcliff. Thank you to the member for Daly. I think it was a very interesting process, being on a bipartisan committee investigating such a weighty topic, but we all pulled together and we delivered. Thank you to the Secretariat. We gave them an impossible task and they did it. So, I hope that in years to come they'll look back on this inquiry and just, be proud that they were a part of this report that will hopefully lead to the last jurisdiction in Australia legislating VAD. Thank you to all the people who made submissions, gave us their time, invited us to their communities and shared their stories to us. It was incredibly heartwarming, the communities that we went to, where people were willing to talk to us and share incredibly personal stories, incredibly personal things about themselves, and we really appreciate that. And I'd also like to thank the Bush members who facilitated us going out into their electorates. Member for Arnhem, member for Barclay, and the member for Goyja, without whom I think we probably would have faced a bit more difficulty getting out bush. So I thank you for your assistance in helping us to go out and connecting us with people who wanted to share their stories. So, themes of the report. So really, it comes down to voluntary, choice, and holding opposing views in tension. So VAD wouldn't work if it wasn't voluntary. If there was any compulsion to it, it would be anathema. But because it's something that the people who want to use it voluntarily choose it, and everyone else who doesn't want to use it doesn't have to. It doesn't have to bother anyone except for the people who are directly affected, who are suffering. I'm just conscious that I only have a limited amount of time. So another tension that was held in the report was the timeline. We were constantly caught in the tension between needing more time to really do justice to the topic, and I think we all would have loved to have more time to write a more fulsome report and consult more broadly, but at the same time we were bombarded with people who were saying, just get it done, just get it done. And the evidence before us was that there would be a significant implementation period once the legislation was passed. So there was no So I hear the contribution of the other members today, and we did have a lot of robust discussions in committee about the timeline, but the longer that we took on the committee, the longer it would take and the more that people would suffer without being able to access VAD. So we did the best report we could in the time we had. And from my experience, I don't think any of the recommendations would have changed. I think we probably would have just gone to more places and talked to more people and had more transcripts. The testimony that we received was broadly consistent everywhere we went, and I'll get to that in a sec. Another point that was held in tension was people who opposed VAD on moral grounds versus the people who were suffering who wanted it. So the people who it directly impacted wanted VAD, and some people who I'll come to later were opposed to it for all, and we needed to hold that in tension and weigh up the options. Conscientious objection. One of the topics that we really wrestled with on the committee was the right of people to not participate in VAD, so that to prevent them from forcing them to offend their conscience, to make sure there were strong protections for people to not participate in VAD if they didn't want to, and I'll come to that later. So our recommendations. So we stood in the shadow of the 2024 report, and in my opinion, it was appropriate for this committee to re-examine their recommendations, given that that report was commissioned by a previous assembly, and it is this assembly here that will be legislating VAD. So it was completely appropriate to re-examine that report and to give that work to a committee to examine, to inquire, and to report back. And we substantiated some of their findings, and we also departed from some of their findings as well. And I think on balance, the end result will be much better for the work of this committee. So we recommended that the NT legislate VAD in a way that respects our unique context, demographics, and geography. So what would VAD look like in the NT if the report was legislated as it stands? So you would have a centralised navigator service, which are the people who are able to connect you with health practitioners and guide you through the process. Importantly, they are not medical practitioners themselves. They can't sign off on anything. They are just navigators. They are able to go into conscientiously objecting organisations when health practitioners are not. You would have a centralised accreditation service. Any health practitioner who wanted to participate in VAD would need to be accredited by NT Health according to policies drawn up by the CEO, and that accreditation would need to be centralised. There would also be a centralised pharmacy, because substances involved are extremely dangerous if misused, so they need to be carefully controlled. Where it would be a decentralised service delivery by the doctors who are already treating people. So if you're suffering from a terminal illness and you have your local GP and your specialist who's coordinating your chemo and your treatment, they could potentially be the doctors who sign off on your VAD consultations, which we thought was appropriate because they would be the doctors that you would be dealing with the most. We didn't want a fly-in, fly-out service where some bloke that you don't, or some person that you don't know, you haven't had anything to do with, and they're a full-time VAD person, and they just fly in, and you have to go through your whole illness and treatment all over again and re-traumatise someone who's already suffering. We didn't think that was appropriate. And we also, I'll come to this in a bit, but we also didn't want to take doctors away from treating people and saving lives and to put them full-time, and I'll try to put this nicely, in delivering a VAD service that will result in the ending of life. We are not so well off in the territory that we can afford to take doctors away from saving lives for that. So we very strongly landed on a decentralised service of delivery in terms of the health practitioners who will be signing off. That VAD in the territory would be justiciable. So there's a whole bunch of things around eligibility and the process. And if there's a problem in that process, people have the right to appeal to the tribunal and to appeal a decision from that tribunal to the Supreme Court. So there's an appropriate oversight of the courts of the process. There's a review board to monitor each and every application of VAD and to report on the process and advise the coroner if need be. The review board is a fairly standard practice around the rest of the country, and it's notably a feature that was absent from the original Rights of the Terminally Ill Act, and potentially could be one of the features that was so objectionable the federal government chose to override our rights. Eligibility. If it was legislated according to the report, who would be able to use VAD? You must be at least 18 years old. Children are excluded. You must be of sound mind, able to give informed consent. And that has some other consequences. You must be suffering and dying of a disease that is progressive, incurable, and terminal. There are a lot of arguments against VAD that go into the slippery slope argument about, oh, well, you know, there's places overseas where this happens and that happens. And so for us, a red line that we drew in terms of the committee and the report was that you had to have a terminal illness. Now, at the same time, we didn't discriminate against disability. So you can access VAD if you have a disability. For example, now that could be mental, it could be physical, it could be neurological, but it cannot be your terminal diagnosis. And the disability must not be so extreme as to remove your ability to give informed consent. So that was, there were a number of submissions that spoke to that, and the key principle that we stuck to was that a person had to be able to give informed consent. And if they could, then disability should not be a reason for them to not be able to access VAD. Similarly, mental illness, we did receive some testimony, but unfortunately it'll probably be redacted in the final version. We did receive a submission that mental illness should be considered, but the committee could not accept that because it's not a terminal prognosis by itself, as it undermines informed consent. Now, we did receive a number of submissions around neurological diseases like dementia and Alzheimer's, and similarly, the committee drew a red line around those for the same reason that they undermine informed consent. So we decided that neurological diseases such as dementia and Alzheimer's cannot be the prognosis, as by the time there's a diagnosis of a terminal nature, then the patient is likely no longer of a sound mind. The flow would be, if someone wanted to access VAD, they would likely have a discussion with their doctor. They may have a discussion with the VAD Navigator service. They would make a formal written request. They would have 2 doctors sign off on that request. There's a cooling off period in there. And once that process is done, the administration would either be at home by themselves, and that's our preferred model. Our preferred model, and it's quite popular in other states, would be that if someone was accessing VAD, they would not do it at a health facility. They would do it at another location, likely their home, surrounded by their loved ones, where they could, say everything that needs to be said, celebrate in a way that's appropriate to them, and then administer the substance and pass away in peace. The other alternative was administration by a doctor, which is medically preferred because you have better control over the substance, but that brings in complications around the location, which I'll get to in a sec. Cultural safety was a very important thing that came up in our consultation, and I'll get to the reasons for the points I'm about to make, but we recommended that VAD primarily not occur in health facilities. So that means clinics, hospitals. We recommend that at least initially, it occur elsewhere. And the reason for that is cultural safety around Indigenous peoples. So there were a lot of issues of blame, misappropriation of blame, misunderstanding of causes of death, and there was a lot of concern that if there were health practitioners who participated in VAD in a health facility and people came to know that and misunderstood the circumstances, that blame might be attributed and then the safety of those practitioners might be in doubt. So for the avoidance of all doubt, doctors who participate in VAD probably would need to be firewalled off from serving on communities or in areas where people who might be threatened in terms of cultural safety would be treated. So what did we find? So the member for Arafura made a good point. How on earth do we get people talking about this sensitive topic? So each session would start with a standard welcome and a briefing, and then we would say, well, tell us about healthcare in this community. Tell us, what's the clinic like? What happens when people get sick? Which will lead into a discussion about healthcare, and if people get sick, they have to be medi-flighted out. And from there, we generally transition into, well, what does finishing up look like on community? When people finish up, what does that look like? And there would be discussions around that. And they would say, well, what does it look like to finish up well? And then we'd introduce VAD and then ask them what they thought about it. Now, the consistent evidence that we found across, I would say, all the communities we went to was that the evidence was that people said, not for us, but if other people want to use it, that's their choice. And that was a really important finding for the committee, that if someone in Palmerston or Wanguri or Fanny Bay or Breitling or Araluen, if someone that they didn't know, they weren't connected to, wanted to use VAD, that wouldn't offend the sensibilities of people in community. They were very clear that it wasn't appropriate in their culture and they had no desire to use it themselves. But if someone elsewhere in the territory who they didn't know and wasn't connected to them wanted to use it, then that was their choice. And we come back to VAD being voluntary, being choice-driven, focus on the people, allowing the people who need it and want it to have it, and other people not needing to be bothered by it. There was a lot of findings about the importance of finishing up on country and returning to country. Pretty much everywhere we went, people said that when they were getting towards the end times and they knew that they were going to be finishing up, they really, really wanted to go back to their country, their community or their homelands and finish up there. Now that introduces a lot of difficulties around transport, but also withdrawal from treatment. We heard a lot of evidence around withdrawing from treatment, and that was a new thing for a lot of us on the committee. The idea that people would voluntarily withdraw from treatment to return home to the place that they know and love and where their loved ones are, knowing that it would likely result in their end. I know someone's going to...
Extension. Member for Karama.
Madam Speaker, can I seek an extension for the Speaker, please?
Is an extension granted? All those in favour say aye. To the contrary,
Thank
no.
you, everyone.
An extension is granted. Please
All right.
continue, Member for Blain.
Okay. And withdrawal from treatment was often brought up, that when people were facing the end, for example, people in end-stage renal failure, when dialysis wasn't working, they would voluntarily withdraw from treatment, come home, go out on... Well, the preference was that they would come home, go on country, and all the family would come in, and everyone would come together, and then, and ideally, the ideal situation would be if they had a clinic nearby or health professionals who could give them pain relief and somewhere comfortable to lie, and then all the culturally appropriate things would happen, and then they would pass away in due time as a result of their illness. That was consistently reported as something that was very important to people on community. Another finding we made, and I personally will admit that as someone who grew up in the Territory around Indigenous people, I didn't realise the extent of this until this inquiry. The extent to which kinship decision-making by consensus is so important. The role of the Djungai. I thank the member for Mulka who brought up before, and the member for Arafura who also mentioned the Djungai. That was mentioned many times in Numbulwar and Nooka, and there were similar concepts communicated to us in Tennant Creek and Papanya. Health facilities, when we received evidence from medical staff, they said that they worked hard to promote themselves as places of healing, not death. Because although death does happen there, if people think that, you know, going to Katherine Hospital or Alice Springs Hospital or Tennant Creek Hospital from a community, if they think people die there, then that will cause hesitancy in accessing health services. So they work hard to promote themselves as places of healing. What else did we find? Well, we had many, many touching, heartfelt stories of people's loved ones in their final times. Too many to share here. The written submissions, there was an incredible variety of written submissions. Some detailed, some one-liner, for and against both NT and interstate. When the committee weighed those written submissions, we held the submissions of Territorians to a higher weight than the submissions of people from interstate. And the weight was definitely on the side of people wanting to see VAD happen. A lot of people, what we found throughout the inquiry was there are a lot of people who are passionate to see VAD in the NT. There are a lot of people who would not use VAD themselves, but their conscience is not offended if someone else where in the Territory uses it. There are a few people who believe that no one at all should have VAD, and we really only received one submission to that effect. On balance, the rest of the submissions were either enthusiastically in favour or that their conscience would not be offended if people were able to access it. So, one interesting thing, in our written evidence, testimonial and personal anecdote, we found that people who had a personal experience of a loved one passing away and suffering in the sort of circumstances that VAD is designed to address, people who had a personal experience with a loved one going through that generally changed their minds and were supportive of VAD. And we had a few pieces of evidence where someone was initially opposed, went through that experience and then changed their mind and subsequently supported VAD. So that was a valuable piece of evidence in deciding to support the recommendation to legislate VAD. We had evidence given to the committee that statistically about 1% of deaths in a state would use VAD. There's about 1,200 deaths a year as a ballpark in the NT. We have a 30% roughly Indigenous population. The evidence was that they would probably not choose to use VAD. So of 800 people, about 1% of that is 8. The evidence that we had from other jurisdictions was that there's somewhat a funnel. So if of 10 people who start the process for VAD, roughly a third will pull out, a third will pass away from the illness, and a third will continue through. So we're looking at about 8 people a year who might use VAD in a fully fledged functioning system. So that drove a lot of our decision making. The NT cannot afford to have a large, bureaucratic, centralised, expensive VAD apparatus. We wanted to have a simple, lightweight model that imposes the minimum cost while allowing access to the people who really need it. The 2024 did a great job surveying the urban centres, and we accepted their recommendation that the majority of people in urban centres wanted VAD. Then the focus became of the people not consulted, would VAD offend their conscience to the point that it should continue to be excluded. So that was the focus of our remote consultation. Where we departed from the 2024 report. So we recommended a decentralised community model as opposed to the centralised model. And that's primarily because we could not, in good conscience, recommend taking doctors away from saving lives to administer VAD for 8 people a year. So we wanted a model where people could use the doctors that were already treating them. We recommended no timeline, which is basically because of the difficulty of prognosis of time of death. We don't want doctors fudging their prognoses. We felt that the requirement that the person be genuinely dying and suffering was enough of a protection for someone who actually wanted to access VAD. So we didn't see a need for a timeline. However, because of the no timeline, we introduced a residency requirement. So I implore my colleagues, when a bill comes to the House, if a time frame to death is introduced, then we should remove the NT residency requirement, given that all other jurisdictions currently have VAD. And it was only there to prevent VAD tourism. Conscientious objection. I won't be able to do this credit. One of the revolutionary things that we introduced was we pushed conscientious objection to its limits so that organisations have the right to object. This was a combination of the ability for Indigenous communities via their health organisations to be able to put their hand on their heart and say, we are a VAD-free zone. There's no VAD happening here if they choose to opt out of VAD. And also, we received evidence from ARCs who come under Uniting Care that their board would not accept VAD on their premises, and so we supported their right to be able to opt out of VAD. And we have a number of protections in the report. I'll try and go faster. We introduced video authorisation for people who physically aren't able to sign. The review board, there were some internal discussions about whether the CHO should be the chair, but I'll leave to the government the best composition of the review board, so long as it has its powers to fulfil its function. There were some things we could have fleshed out more. The member for Goyja said that we should have consulted with everyone. I think he confused consultation with education. So in the first interim report, we wrote to everyone. And for the record, for Hansard, I'm holding up multiple pages from the first interim report, and you can go and have a look. We wrote to everyone, all the land councils, AMSANT, health organisations, everyone we could find. We wrote to them all and said, please make a submission. We'd like to come out and talk to you. Please, can we come? And we went to the places who agreed. So we would have loved to go to all those places that the member for Goyja named, but they didn't accept to have us come, and that's their right. So we didn't go. It's not because we didn't want to. We had time. We had spare capacity. They didn't want us to come, so we didn't go. So things that didn't make it into the report. Interstate specialists will need to be accredited as NT VAD practitioners so that locums and people travelling interstate for care will be able to use those specialists for their sign-off. We had evidence from the Alice Springs palliative care team that doctors have a bias towards treatment, even in the face of terminal illness, and that it would be a culture shift for them to consider recommending withdrawal from treatment. We should have recommended that NT Health take a more holistic view of end of life and consider updating training around end of life discussions to ensure that patients are more aware of that option. I'll skip forward to my wrap-up. The objections of the few who think that no one should access VAD and the large number of people who personally don't want it should not prevent the small number of people who are suffering directly from accessing the service. In many areas, I believe that if we ban access to a service, we create black markets in the thing that is banned. We should have a careful, controlled, compassionate, well-regulated option so that dignity can be maintained at end of life. My personal vote on this bill will be determined by the response of my electorate. Some in my electorate are deeply opposed to VAD, but so far I've been overwhelmed by the people reaching out to say they support VAD and they want me to vote for it. Thank you.